All right. Hi, everybody. Welcome, and thanks for joining us at this month's series of the MD4SG Colloquium. Our Colloquium series serves to highlight exemplary work on improving access to opportunity for disadvantaged and marginalized groups through this talk series. So for our second talk of this spring semester, we are very fortunate to be joined by Dr. Ruchit Nagar, who is a combined internal medicine and pediatrics resident at Yale. He's also the co-founder and CEO at Cushy Baby, a digital nonprofit working as a technical support partner to the Department of Health of India's largest state, Rajasthan. I also want to highlight that Cushy Baby actually started out as an undergrad project when Ruchit was an undergrad back in 2014 at Yale. So Ruchit then trained at Harvard and Yale for his medical and public health degrees and has been recognized as a Forbes 30 under 30 leader in healthcare, distinguished young alumnus at the Yale School of Public Health. And his interests include critical care, healthcare systems change, impact evaluation, and machine learning for global health. So we're really lucky to be joined by Ruchit today to give insight on his perspective as more of the practice side of this research practice pipeline, in particular because he has extensively worked with AI researchers and partners throughout some of their work at Cushy Baby. So over to you, Ruchit.
Thanks so much, Lily, and thanks so much, everyone, for your time. Let me just share my screen real quick. This one. All right, I have some slides, and then also we can keep it very informal, and please feel free to interrupt and ask any questions. So my name is Ruchit, and I wanted to tell you a little bit about Cushy Baby. My, objectives for this talk are to highlight these 3 points broadly: that public health in India is undergoing a major digital transformation, that community health workers are creating new big data sets. And the question for us that we are working on is how we can leverage this data to drive impact at the last mile. So first, I want to talk a little bit about the Indian public healthcare system for those who may not be familiar. So it's based on a decentralized structure. India has about 900 million people that live in rural settings out of 1.4 billion people. And in that way, the village is kind of the unit structure. And in each village, there is a community health worker that the village elects democratically, known as the Asha. This is a picture of an Asha that's going door to door in her community, basically reminding pregnant women to come to the health camp that takes place on a monthly basis. She has to do this along with many other tasks, but her role is as a health mobilizer. Now, when she does this, the beneficiaries may be out, collecting crops during the harvest season. The season may be arid. These are pictures from Rajasthan where we work. And, if you're lucky, the pregnant woman's bringing her child now to the health camp, which looks something like this. It's outside of usually a closed school building or some other makeshift building where you have a kind of indoor-outdoor basic health camp. Paper-based health records are still being provided. You have spotty internet connectivity. This is the nurse now who comes and visits. She's called an A&M, auxiliary nurse midwife. She flips through her register. She tries to identify the patient, then tries to understand which vaccine to give to this baby, and then polio is given. So that's the process, and you can imagine that there's a lot of challenges in terms of access, in terms of awareness, and in terms of ultimately the quality of care and that is able to reach the last mile. And the things that we want to do is we want to understand how are digital systems interacting with this environment. So the project that Cushy Baby started basically 8 years ago with this as the problem statement. We were focused on child immunizations and trying to improve that workflow. And what we had done is we had made a mobile health application for the health worker. And then we were trying to see if we could make a wearable, portable health record for the beneficiary that could replace the paper. And one of the early insights that we saw was that, these kids were wearing black necklaces with black thread to ward off the evil eye. And it was kind of an aha moment for us in which we could use that traditional thing to tie with technology. And we actually tied an NFC chip with the black thread and used that as a digital pendant and a wearable vaccine card for these kids. And this was something that got a lot of support from the communities that we were working in. And in a way, this was kind of a starting point for us and really underscored the need for us to think about culturally appropriate and locally accepted solutions. We had initially gone with silicone wristbands and other kinds of things that could be wearable health records, but this is the thing that stuck when we were doing our initial pilot work. And this is the health application that I referenced earlier. We had an Android application that we made for the A&M nurse, which would basically help guide her decisions on what vaccines to give on a particular day, what the growth chart looked like for the baby, and then a summary page for her to take actions. Now, all of this worked offline. The digital pendant with the NFC chip also allowed you to retrieve information in an offline manner as well. And because of the communities that we were working at, you had limited internet connectivity. That was an important piece to build into our design principles from the beginning. So the next step was for us to actually see if our overall digital intervention could improve infant immunization rates. So we did a 2-year randomized control trial following 3,000 pregnant women. And we were able to actually get good, positive results in terms of public health significance. If you look at the absolute difference increases in immunization rates for areas that were randomized to getting the digital health intervention versus those that were not. And our intervention included the necklace that I showed. It included the app, and it also importantly included a voice call reminder system in the local dialect. So not in Hindi, but in the local Marwari dialect, using a female's voice to motivate the mothers to bring in their children at specified times to get vaccinated. And if they missed their due date, to then give them a message saying that, hey, you missed your due date, please come to the next month's camp. And to give them a thank you message if they did go to the camp at the right time. So these were very promising results, but this was really just a starting point because it was still a pilot project. Health workers were still having to use the other government protocol systems, whether that's writing things on paper, having data entry operators type it up into a portal. And they had other work to do besides just taking care of immunization of kids. In fact, as we spent more time working with these health workers, we realized that it's not just the nurse, really it is the ASHA worker who I referenced earlier, who's working with the nurse, who's working with the doctor, who's at the referral center. And the ASHA worker herself has 10 different registers, one for each one for an individual national health program. So, there are multiple barriers ultimately that we were beginning to identify to empowering the community health workers. These included still paper-based record keeping, poor data quality, especially with regards to denominators. The digital health systems that were coming out were in silos. And then health workers were not being valued for the data that they were being collected. It was just more of a reporting tool, not necessarily a tool that they can generate insights from, and not necessarily something that would even accelerate their productivity or time to getting paid. The community health workers get paid on an incentive basis for 42 activities that they do, but that incentive comes, 1 to 2 months after they submit their work. And then, the health workers are not just covering immunization, they're covering these 3 broad buckets: reproductive, maternal, neonatal, child health continuum, non-communicable diseases, and communicable diseases. And the government of India and various state governments are coming out with multiple different applications for some health workers, but not all 3. COBIN is one that I'll highlight, which was used to actually track 2 billion vaccination events across India. So one of the largest single purpose digital health tools, and that was developed in the last 2 years. But still, there's a problem here, right? I mean, if you're having to enter data again and again, and there's some level of redundancy, that doesn't, instead of juggling 5 different registers, you're juggling 5 different apps. So that's where we kind of came up ultimately with our solution that we're scaling up and implementing now, which is called CHIP, or Community Health Integrated Platform, and provides a unified offline mobile interface for longitudinal care coordination across all of the different national health mission programs, which I've listed in the top right over here. And that data flow should be seamless. It should be able to be working offline. When internet is present, you should be able to connect. You should be able to get notifications that, oh, somebody went to the doctor, and this is the follow-up that I need to do in the community. All of that needs to be coordinated together. And part of the design process is working directly with the health workers. So we've spent over 180,000 hours collectively working in the field, because we have a team of 15 field monitors that work in the field every day for the last 6 years with the health workers, doing IT support, capacity building, helping with high-risk beneficiaries, logistics support, trainings, all of that. And the broader point here is that we have an interdisciplinary team that, in order to deploy this solution at the ground level, it requires people working at the policy level with the Department of Health, people that are making the solution, people who are implementing the solution, and people who are evaluating the solution as well. And the platform has since scaled up. We have around 20 to 30,000 daily active community health workers on the platform. We've reached over 34 million unique beneficiaries, and identified about 10% of them with some high risk factor. And we have 6 or 7 million geopoints, each of them corresponding to the village level, where somebody could drill down and actually do remote monitoring, follow up with a specific health worker for various different disease categories. And this all actually was jump-started by COVID and doing community-based screenings for COVID back in July of 2020. And during that process, we also would ask for comorbidities. So that's how we got a lot of information about malnutrition, anemia, tuberculosis, HIV, heart disease, hypertension, diabetes as well. So the platform has now been used beyond COVID across multiple different, all of the major buckets, to varying different extents. And it's really now become a base for every department, every program within the Department of Health to use as a kind of single source of information. This is a little bit about the timeline of activity. So we started with COVID back in 2020. And from a policy standpoint, you're a new system that's trying to come in. How do you get buy-in? So COVID was a moment for us, but then, after seeing the success of COVID, we worked with the Infectious Disease Surveillance Program, who had vector-borne disease campaigns that they wanted to monitor for at the community level. There was a smoking cessation campaign, a tuberculosis active case finding campaign, a measles and rubella elimination campaign. So all of these different health campaigns that were related to different programs allowed for the sequential uptake of the system in in a stepwise manner. So we've collected all this data. Obviously, next question, let's start doing something with the data, but we need to pause here and ask questions about data quality first, because this is still a huge issue. And Arnish and I have worked with others on this question specifically. So, this is like this is just a bar chart that shows the different reported diseases during our most recent health census activity, where you can see, okay, hypertension, diabetes, lung disease are towards the top. You have a high number of others, but what you're not seeing here is 90% of people have none as their reported disease, right? Having no disease, Probably not. We know that the rates of anemia in Rajasthan are over 50%. We know the rates of diabetes and hypertension are probably closer to 20 to 30%. So there's definitely a massive amount of underreporting that's taking place here. So now we have to start to think about, okay, who are our champion health workers? How can we extrapolate from this data and those types of questions? If we look at patient level data, right? So just going a little bit more granular. So these are hemoglobin values for pregnant women. And, we see certain spikes at nice round numbers. Same thing for blood pressure. We see a spike at 120. Now, why are we seeing these spikes? For hemoglobin, it actually has to do with the test strip. They prick the finger of the mother and they put it on a test strip, and you can either pick 12, 10, 8, or 6 based off the color. Does it look pink? Does it look red? Does it look dark red, etc.? And so there is some lack of the ability to be precise here. And for blood pressure, sometimes there's a rat that is literally eaten the blood pressure wiring, and it doesn't work. So what do? They don't have a new blood pressure machine. They'll just put a normal value. So we definitely do see that. It's in some cases they have some automated blood pressure meters, but in other cases they're just showing that the blood pressure is normal. And you'll see, there aren't that many people that have a systolic blood pressure above 140 or 150. And we know that maybe 5 to 10% of women will have preeclampsia or pregnancy-induced hypertension, and they should actually be in this range. So again, missingness of data. And you have to also start to think about what are the incentives around people reporting poorer health outcomes. If the incentives are, I want to see good health outcomes, I want to see 90% immunization, I want to see all of my pregnant women getting 4 checkups, I want to see everyone healthy, then why should I report that somebody's sick if that's just going to cause me to be kind of punished in some way? So that kind of moves us to the next part, which is trying to think through how do we bring out data phenotypes. Obviously not all health workers are working in the same way. So this is just doing some unsupervised clustering on 50 different columns of data that the ASHA workers are collecting, and trying to see if we can get some separation in terms of where there are champion health workers, where there are health workers that are just not reporting data on many of the columns. So this is kind of an unsupervised way to do this. But in working with RNH, we did more of a there's also a more structured way to look at it, in part by looking at some heuristics. So when we think about data quality, we think about, first of all, do you have sufficient quantity for us to even ask the question about data quality? If a health worker has just, done 10 checkups, there's 1,000 people in our village, then we can't really say much either way. So that's a prerequisite. But then, have they been making unique records? Have they been making, this is just even during the census, have they made unique records? Are they making zombie records? How much of the optional fields have been completed versus skipped? When it comes to the suspected diseases and health behaviors, are we seeing things that are consistent with what we would expect from our prior literature knowledge? Or are we seeing, different proportions of hypertension and diabetes that wouldn't make any sense? It definitely shouldn't be 0% for diabetes, right? Numerical variability. So this, looking at the actual statistical variance for the blood pressure value, we saw how it was, having certain spikes, as opposed to, is that more of a normal distribution? What does the variability look like? And then also contradictions. So in some cases, let's say the nurse says that for one patient, she says that, oh, I don't have a working blood pressure cuff. But for a subsequent patient, she enters in 120/80. Well, it's not like she magically got delivered a working blood pressure cuff at that camp, right? So we look for certain contradictions like that as well to help us understand the data quality. And we can use these things to make scores, and we can normalize those scores. and then we can actually rank people based off that scorecard.
Can I ask a question here?
And after we rank them, we can also track it over time. So this is just like a time lapse that shows over space and time, how the data quality is improving. And definitely this will change as health officials push for certain campaigns, or as different areas start to get onboarded and get trained. The data quality will fluctuate from week to week. And then you will also see like a retention effect, right? So after a few weeks, people will finish their surveys and they'll feel like their work is done, and then they'll just stop. So in thinking about data quality and explicitly measuring data quality, then we can begin to answer some of the questions that are relevant for public health, and using data quality as something explicit in our modeling. So from a community health standpoint, oh, sorry, yeah, go ahead.
Thank you so much for all of this so far. So when you found, like, I don't know, 10% of the data in one state is not good, what action did you take there? Did you throw it out, or do you just kind of downweight the data in that entire state for that week and do your later estimates?
So I think so there's a few ways that we try to handle it. Like, whenever we get data, we're trying to do some verification exercises on a random sample basis. We're trying to identify who the champion health workers are, and even see where they have room for improvement. Where we see that there are outliers, and recently we found, okay, there was some community health worker that reported like 1,000 cases of TB in her village. We will exclude the data from the data set, or we'll like go back and revise it. It does get difficult when you have so many health workers, and when population densities are slightly different, depending if you're working in an urban area or a rural area. But yeah, there are some absolute cutoffs that would trigger an alert for us, and we would reach out and try to correct the data directly. For missing data, I mean, that's something that we try to just address by more trainings. We have the ability to send push notifications into the app of the health workers. And we also are in like over 300 WhatsApp groups with health workers across the state. So we are also, sending mostly generic messages, encouraging them to improve how they can improve their data quality. And what we want to do moving forward is use the score to actually make a like social competition in a way, like gamify it, where there's a leaderboard and you can actually see, okay, hey, I had the best data quality, I got the gold medal or silver medal or whatever equivalent that is, and tie that with some social recognition. And I think ultimately with the data quality, the other thing is like education about how, if they submit good data, how they can actually use that data themselves to improve their own like workflow. I think that's the most important piece. So, you can only do top-down mandates for so long, but if the thing is not intrinsically bringing value to the health worker, then yeah, why should she spend more time on it? And why should she like try to get everything right? She's the one who ultimately has to take care of the patient. So there needs to be features within the application, things like helping her plan, or helping with submitting reports, or summarizing stats, or seeing like a breakdown of her village. Clinical decision support in real time as she's entering data. She can see that, I entered a blood pressure of 140/90. Like, okay, now it's telling me I need to check for the urine test. I need to like repeat the blood pressure. I need to do a referral. So those kinds of things increase the data quality, we think, more than others, more than just messaging. It's really about making the system improve the productivity and workflow for the health worker.
Awesome, thank you so much. And then one question from the previous section from Jessica Nociaro in the chat. So she asked, can you clarify what you mean by reaching the last mile?
Yeah, so reaching the last mile is typically thought to be like the, analogous, so you can say like the bottom of the socioeconomic pyramid, those who have the hardest access to care. The communities that we are working with may be like 60 miles away from the nearest district hospital, for example, where they have tertiary care services. So, but the last mile can also be thought of a little bit more broadly, in the sense that you do also have underserved communities in urban settings, and like you can like in urban slums, for example, where it's not physically a last mile, but in terms of the health worker to population ratio, and in terms of the actual access to care, you still in a way are at the last mile. So it's really become more of a broad definition, in my opinion, to talk about underserved communities and access to care.
Thank you so much. And then a question now from Divyendu Mishra, who asks, could you expand more on the reasons behind the poor data quality? Is it cognitive overload, being overburdened, or are there deeper structural inequities affecting this?
Yeah, so there's definitely work burden in place. These health workers have to juggle 10 different programs, the ASHA workers up to 42 different activities. Every new survey, every new campaign, they have to basically do. And a lot of it is redundant information, writing the same names of the same people in different registers. They spend around 20 hours in a month just compiling and tabulating things, and then putting that in a format, and then traveling to the nearby health center, sitting with a data entry operator who types it up into a system, 1 month after which they might get paid. And they might have to give they might have to bribe the data entry operator if the data entry operator is corrupt, or some data might be manipulated at that point in order to make it fit in the system, because the system has validations that are not accepting the real data, because the system is designed to make the data look more good. For example, the system wants all of the pregnancy checkups to be evenly spaced apart in each trimester. But let's say somebody didn't come exactly evenly spaced apart, then it doesn't accept certain pregnancy checkups because the date is off. So there's all kinds of structural issues. And then I think the other thing is, 50% of the estimated maternal and child mortality is actually reported. And with that, there's fear of punishment, there's fear of having a review of basically punitive action. The government of India tries to say that we want to do supportive supervision when you have health indicators that are not doing well. And in some programs, they're starting to really emphasize, we want to find people that are sick. Like that is starting to become a top priority outcome. And tuberculosis is one of the areas where that has really been shown. Like we're doing active case finding. The more people that you find, the better. Because only if you find them can you treat people with TB. I think there needs to be more of that in terms of identifying those people who are high risk and incentivizing that, as opposed to incentivizing the opposite, which is still the common perception.
That was super insightful. Thanks so much. We'll let you continue for now.
Yeah, no worries. They're great questions. So I'll talk a little bit about community health, trying to figure out which communities are most vulnerable and where we need to target our resources. So I'll start off with this, which is, this is a map of the multidimensional poverty index, where green is more socioeconomically well off and red is socioeconomically poor. On the left panel, you have a map of India. And this was data that was compiled in 2021, looking at the most recent representative family health survey. And you can see that it has like 600, around 600 districts, and each district is a color that corresponds to their economic, multidimensional poverty. Now this blue square is the state of Rajasthan where we work. And this is now the type of resolution that we've been able to collect. And we're just visualizing the data right now at the census tract, or at the kind of zip code level. It's not exactly a zip code, but it's the census tract level, about one census tract is one village, you can say. And you can see the degree of granularity that we're now able to just visualize. And then the next step that we're going is, can we actually fill in these gaps, these gray areas? Can we fill those in? So this yellow box over here is one district of Udaipur, which I've put over here. And you can see that we're using some geospatial analysis techniques. We used ordinary kriging for those who have done some geospatial analysis to basically come up with a probability distribution of how we would expect the poverty to be distributed over this particular area. And we had actually so many data points. We had several 100,000 data points from this district that we had to randomly sample 20,000 for us to be able to even run this analysis. And now we're in the process of actually replicating this across the state. And what's interesting, and I haven't shown here, is that you can also, with this, you can generate a corresponding graph that shows the areas where you're most confident and least confident based off the amount of error that is in this model. So, it'll highlight that this area, which is actually the hilly area, not a lot of people live, we don't have that many data points that were actually sampled, will be a higher degree of uncertainty would be highlighted here. And what's cool about this is now you can, once you fill in the gaps, you can start to say, okay, I'm starting in the city center and I want to go and do, malnutrition screening camps. Am I going to turn to the right or turn to the left when I do my little drive? Well, I'm going to go this way because it's darker. I mean, darker is worse in this image here. But I'm going to go here and I'm going to try to get this area as opposed to getting this area. So those types of even village to village microplanning can be assisted with this type of resolution. And there's actually a saying in India, like I'll roughly translate it, every like few kilometers, the taste of the water changes, which really does, what it means to say is there's a huge degree of spatial heterogeneity and a huge amount of variation in socioeconomic and other kind of demographic strata, even if you move a few kilometers one way or the other. The other thing about this information that's really interesting is that, so it's a multidimensional poverty index that was basically collected out of a health survey, because we also ask about social determinants of health. But with this type of data, you can imagine that the education department, the public distribution department, all these other departments, women and child department, would love to actually see where the places are more multidimensionally poor so that they can also implement their targeted services. The next thing I want to show is, oh yeah, I'll pause. Yeah.
There's a hand from Nikhil.
Yeah.
I think you were in or you had answered it. I was about to ask how you sort of deal with heterogeneous underreporting and sort of things like that in that map, but you touched on it.
Yeah, so I mean, that was definitely a thing. Like, in order for some of these models, you need to have some degree of homogeneity in terms of at least the sampling. And we would have issues when we tried other approaches. We were initially trying to look at smaller geographies, but then we realized that we had more surveys from certain geographies. So then what we ended up doing is we took a larger area and then randomly sampled across that. And because there were sufficiently enough number of surveys, it was able to then perform the model without breaking, essentially. Because if we were trying to go like sub-district by sub-district, we were having that issue that the points were too far apart. It wasn't homogeneously distributed. It couldn't interpolate in between. So that, like, doing it in bite-sized chunks, which would save our computer memory, and we were going to try to stitch it all together, didn't actually work. So then we had to like basically randomly sample and pick a bigger area where it would be more homogeneously distributed at a larger space interval. And then it helped actually run the solution. And there's other things that we can do moving forward. We can also do something called co-kriging, which is you can add a multivariate version of this, right? This is just looking at one variable and using data from one variable to like data from the colored areas to predict the areas where there are gray. But we can also do a co-kriging where imagine multiple layers of this map, right? And on other layers, we have some colors in the gray zones. So we can use those other variables that are present in the underreported zones to also help further estimate. Of course, that makes the computational complexity go even through the roof. We don't have the supercomputer power to like do that, but I think there's a lot of interesting, probably people who have done optimization work and who have thought about this and doing it in efficient ways.
Thank you.
Yeah. So after we kind of fill in the gaps, I would say one other type of analysis that we try to do is trying to identify the spatial outliers. So there are different, like, I guess, techniques that can be used. We used local indicators of spatial autocorrelation, or LISA for short. There's other clustering techniques, DB scan. I'm not super familiar with all of this, but what we use, basically, I can kind of interpret for you. So we have 3 different maps here. One is for malnutrition on the left, one is for diabetes in the middle, one is for tuberculosis on the right. And what you're seeing here is the red areas. These are census tracts where you have a high amount of prevalence in a high neighborhood of prevalence. The orange tracts are, you have a high amount of prevalence, but the neighborhood is cold or low. The cyan or light blue is you have a cold amount of prevalence, but the neighborhood is hot. And the dark blue is you have a low amount of prevalence and the neighborhood is cold. And what's interesting about these statistical outliers is that each outlier group has its own different questions that you can ask about it, and its own set of interventions that would come with it. So, like, for example, the high prevalence, high neighborhood, okay, that's a hotspot. We need to, like, curtail the outbreak. We need to send people there. That's pretty straightforward. But what's interesting is, like, okay, one of the orange spot, like, this is a hot area in a cold neighborhood, which means the surrounding neighbors may be susceptible to spread, for example, or there might be it might be a negative deviant. Why is this place worse when everything around it is doing okay? And on the flip side, the sky blue, maybe that's a positive deviant. Why is this place have such a low rate of whatever disease, but all of its surroundings are high? And the dark blue areas may be areas where everything's going great, or it's an area where there's just underreporting. So every color has, like, a different set of questions that you can start to ask. And then, the resolution is also helpful here because, again, you can really target it to the village level as opposed to a whole district. And then one other thing that we're trying to do is try to understand the spatial predictors or spatial drivers or spatial correlators or factors, however you want to call it. But what are the things that are spatially relevant with our outcome of interest? So here I've taken a look at tuberculosis, and on the left, we're looking at the association between malnutrition and tuberculosis. So in these dark red areas, these are the places in Rajasthan where tuberculosis and malnutrition are strongly correlated. In the middle, the dark red represents HIV. And then on the right, it's working in a brick making factory or in a mining industry. So this is relevant, not because necessarily the malnutrition or HIV or working in a brick factory caused the tuberculosis, but at least when you're thinking about your intervention design, you might want to think about addressing this co-occurring factor that may be related, may be exacerbating, may be contributing to your underlying outcome. So we used a technique called multivariate geographically weighted regression to basically do in a way, a regression analysis, but also account for the spatial autocorrelation as well. I don't know if, and Lily, please stop me if there's any questions or anyone's ask questions. I'll keep going, a couple more slides. So we're trying to use this to also understand the interaction between climate and health. We're already scraping different types of climate-related data that can get us a sense of various different diseases. Think about heat-related illness, zoonotic disease, waterborne disease, injury and displacement. and also map the different health facilities to figure out, do we need to strengthen certain health facilities? Do we need to make new health facilities in certain areas? So there is also, this geospatial analysis naturally lends itself to looking at the intersection between climate-related factors and health as well. And then this is one last thing I want to show, like, okay, how do we like do something with this data? It's a little bit blurry. The GIF kind of came out weird, but we have a dashboard, right? And it'll loop. So on this dashboard, the health official can drill down into an area. And when they drill down, they can actually pick an intervention for that specific indicator. Like in this case, they're doing a messaging campaign for improving antenatal care coverage. And they can select, okay, do I want my message to be like an AA test, a randomized trial, A/B test? When do I want to send it? And when do I want to see the results? This type of tool already exists on things like Google Firebase when developers want to see if a blue button or a yellow button will increase their click-through rate. And we're trying to actually gamify our health dashboard so that way health officials can also see if their messaging campaigns and other interventions can actually improve health outcomes in a similar way. So this is one way that we're trying to actually make the data actionable. And we can get more into that. There's a lot of this is a very early stage. There's a lot of complexity that goes into it in terms of understanding sample size, understanding what happens when you have co-occurring interventions, how many interventions do you want people to be able to do in a certain amount of time span, like their messages, and there's also like events, like if I schedule a camp or a training or a mobile van to get deployed, how do those interact? How do you optimize all of that? There's a lot of like operational research that we're just at the tip of the iceberg of. And even, you know, not all of the interventions that you schedule through that tool will actually make it to the ground, right? Some of them will be implemented, some of them will not be implemented. Some of the messages that you sent in your messaging campaign will be open, some will not. So there's also even work where you can try to do simulation and like this kind of, you can say propensity-based matching, simulation, digital twins, where you can see, okay, if this person were to have received the intervention, like what would have happened potentially. There are ways that we can also like multi-arm bandits, like, okay, instead of just doing a simple A/B test, like what would happen if in the background, you know, you have a machine that is just adjusting things in real time and trying to figure out which balance of interventions, whether that's messages and or events, what balance of that is actually going to give you the best result for your set of outcomes. And we have a lot of outcomes also. So it becomes a huge space for both. You could say you have 5 or 6 interventions, but you have hundreds of outcomes that you could be looking at across hundreds of geographies. So how do you even begin to start thinking about that from a statistical standpoint and from an operational standpoint? Our first goal is just to make the dashboard gamified and fun and exciting for the health official, because then you get more traction and you can first start to learn from how are they thinking about interventions and how are they like, they can also give us some initial data about some interventions that worked and didn't work. But then after a while, you want to get to a point where you could even recommend that, hey, for this indicator, why don't you try these 2 interventions and let's look at the results in 2 weeks, you know, something like that. Obviously, there's a lot of work to get to that end goal. So I'll talk a little bit about individual health now. So you talked about the community, and then we want to talk about individuals. Here we make individual model, like risk prediction models. And the example that I pulled out here, 2 examples. One is which pregnant women are likely to drop out of care, and which pregnant women are likely to have children who are severely underweight at the age of 2 months. So looking far into the future. And we have, data, sizable data that spans like a 4 to 5 year period. We looked at multiple standard models. Usually random forest came out to be the best for us. But what we try to really highlight in this is to make it explainable and identify predictive factors using things like SHAP analysis, and understand that there's some factors that are early on in this time course of pregnancy to childbirth that you can intervene on. There are some factors that are not even mentioned in the literature, but might come out in our data. So for example, tetanus vaccination is not something that would come out in the literature as a predictor of the mom's tetanus vaccine is not necessarily a predictor of whether or not the child is going to be underweight at 2 months of age. But in our data set, that happened to be a predictor, or happened to have some significance. And then also trying to figure out what are the strongest things based off that CHAP analysis that are contributing most to that overall prediction. And we also have made a dashboard. It's not working right now, it's some internet issue, but where you can play with the different weights and biases, and you can like kind of see what the prediction, how that would change the prediction. So this is one thing. Now the next question is, okay, well, we can predict who is likely to drop out, given that the model says that they're likely to drop out. We can predict who is likely to be severely underweight, given that the model says that they're likely to be severely underweight. And we have good improvements in our pre-model to post-model baseline, which is like your pre-test probability to your post-test probability, or positive predicted and negative predictive values. We haven't done this yet, but we're thinking about ways that we can include a human in the loop, right? So we want to first give a generic summary message that says that, okay, this mother is anemic, blah, blah, blah. These are like standard messages that have standard rules. But then after that, we want to get a sense from the health worker, like, hey, what did you think about the risk of a maternal outcome or a child outcome at the time of delivery? And they can like put it on a Likert scale. And then after we get their feedback, we can say like, hey, based off our model, this mother might be at risk of dropping out, or this future child might be at risk of being low birth weight. So just consider referring them, or consider paying close attention. We won't say much more than that, but the whole point is just to make sure that they're aware that this might be higher risk for more nuanced reasons. And it'll be interesting for us to see like, what is the health worker's impression through this Likert scale? What is our model predicting? And then what is the actual outcome? And what's the difference between these three things? And that can tell us either that we need to improve our model, or it can tell us that we need to help improve the intuition of the health workers who may be off from the actual real outcomes that take place. The other projects that we're working on for individual health happen to do with helping the health worker actually screen for diseases. So on the left, we have a picture of one of our team members showing her inner eyelid, the conjunctiva, and we're actually taking photos of this to predict anemia using deep learning techniques. So this is work that's come out in the last year or two for people in emergency rooms. Like, oh, can we take photos of the pallor, the pinkness of the inner eye or the tongue to look at anemia? And doctors can definitely find this out. If somebody's severely anemic, their hemoglobin's less than 7, it will look like almost white. But what is tough is when somebody's moderately anemic, when somebody's between 7 and 9, there's poor inter-rater reliability when different physicians look at the eyes. So this is definitely a place where deep learning can come in and help us. It's interesting about these areas, the eyes and the tongue, is there's no melanin. So skin color should not affect these algorithms, but it's still a challenging thing. And you have to think about light reflection, shadow, blur. If you're working in the field, you're not going to have a fixed lamp that is going to control everything. So what we're doing is we actually have a light, every camera has a light sensor. So we're capturing the lumens of every photo. We have a white balance with the, using a white paper. The model will have to pick up on differences between the color of the target region and the white balance, and consider the overall lumens of light in the photo. And we're actually doing this specifically for pregnant women. Why pregnant women? Because pregnant women who are moderately anemic should be getting iron infusions to help reduce their risk of potential really serious delivery complication with hemorrhagic bleeding, and to help improve the nutrition of their future child. So this is a reversible condition that we can identify by using a non-invasive technique that would be a game changer. And every Thursday of the week, up to 25 million pregnant women across India over an annual basis are getting their fingers pricked and getting the blood looked against a color scale, which is 12, 10, 8, or 6 in the middle of like a rural village. Now imagine all these health workers are having phones in their hands. They can take photos. It can tell them that, hey, there's a high likelihood that this mother is moderately anemic. Please refer them for further testing and further treatment. It can really help drive more people to getting the access to care that they need. We know in Rajasthan, like over 50% are moderately anemic when they're pregnant. So it's a huge, already known issue, but we can even refine that further. On the right is an example. I won't go into too much detail because we haven't really studied this as much yet, but and others have done it, but it's looking at the spectrograms of cough audio and trying to see if this cough spectrogram using, again, deep learning techniques looks like a TB cough versus a non-TB cough. So when health workers are doing their TB active case finding drives, instead of just doing a questionnaire, they can also have the person cough for 10 seconds, and based off the frequency and pitch of that cough, in a real world setting, they can also help risk stratify. And this means that you need to do things like signal isolation and figure out how to make this as real world as possible. Previously, when they were doing this type of work, they would have somebody come into the clinic and they would have a Shure microphone, and there would be like a soundproof box, and they would cough into that. That's not the real world scenario that ASHA workers are going into. They're using, phones with 4 gigs of RAM. There's like Android 8 or 7, and they're going to be recording somebody's cough from right behind them, right? So we need to be able to train the model for the real world situation. And the model needs to be able to be quantized into a phone as well. So even if you have a super high performing model, but it can't run offline, then tough luck, right? Like then you're not going to be able to get the decision support. So yeah, just take a word to thank all of our collaborators. We're working with a lot of different people and where we've gotten funding from. And I'll use also this to as a call to action. Like we have huge public health data set, and we are looking for collaborators to help us work on big data analysis problems. We don't have the capacity within our team to take this on alone. So we're definitely looking to partner with research organizations. And the data sharing piece of this is that people can get involved at the study design phase. People can get involved in terms of working with synthetic data that is not our data, but kind of looks a little bit like our data, but has no identifiers. But so you can still get some kind of insight out of it. And we also have Google Collab. I mean, there's different ways that we can now collaborate, and we're really looking forward to doing that. So I'll just pause there and open up for questions. I do need to run in 5 to 10 minutes, so I won't be able to stay for too long.
Thank you so much, Ruchit. There's many kind of virtual applauses happening in the audience. And for anyone in the audience who is not aware, so Ruchit is a trained physician. He's a resident at Yale right now. He's currently in the hospital, so he's calling us from the hospital. So just thank you so much for taking the time to present to our community. And I also want to emphasize that Ruchit has no formal computational training. So the fact that you're using language so comfortably, like human in the loop and propensity scores and multi-armed bandits, is just really a testament to how closely you've kind of forged these partnerships across the work that you're doing as a physician, running this nonprofit, and really working with computational researchers. So it's really such an inspiration and something that I think a lot of us in the audience would like to strive towards from the other end of the spectrum. So any questions from the audience for Ruchit? Please feel free to just raise your hand or unmute. Okay, I did want to ask, oh, go ahead, Anna.
Oh, I can go. But thank you so much, Ruchit. That was really, really wonderful to hear about, and so many dimensions of the study and the different types of issues with the data and analyzing it, which I thought was fascinating. I was wondering, what kind of do you encounter any challenges with working with local councils or local governments when implementing this? Are there any obstacles through which scaling up the operation of Ruchit Baby that you have encountered as, operations on the ground go and things like that? Be curious.
Yeah, no, it really needs to be a full team effort. We had initial difficulty as a new nonprofit organization trying to work at the Department of Health, where you have UNICEF and JPIGO and WHO and all these big players who have been there for decades, right? And I think it took some time for us to get a seat at the table. Luckily, we had some advocates, the health secretary at the time, and I think the other thing is that we were able to bring a new expertise, which is this digital health expertise on how to build a digital health solution, and even analytical expertise in terms of trying to push the boundary of what type of analysis that we can do from the data that we're collecting. That, of course, had to be supported with an operational team, because you do see situations where there's a software development house that builds a solution for the government and then hands it off, and then the government is left to implement it without being given the proper capacity building or support. But we knew going in that it's going to need to be an ongoing kind of long-term relationship, and signaling that you're there for the long term and slowly building confidence through going from project to project is ultimately what helped us in the long run. We didn't we're not charging the government for any of the services or the platform. It's totally free of cost, and that's in our legal agreement as well. And we actually work with the government to help draft policy briefs and apply for funding from the central government for state-specific innovations. So, so this platform is actually being scaled up across Rajasthan and has a budget approved by the central government of India of like $13 million. So that way, and that money is all going towards health workers being able to buy their own phones and have data plans to actually run the solution. And a little bit goes towards training, but none of it really comes to us or anything like that. So we really try our best to make it integrated as part of the program. And then, yeah, you have to just kind of be there and show that you want to stay.
If there's any other questions, please raise your hand. Otherwise, I have one, Ruchit, about the fact that you ran an RCT with over 2,000 or 3,000 patients. I think that's really incredible. That was over 2 years at such a big scale. But how, from your perspective, can we incentivize more NGOs to do things like conduct more scientific experiments like an RCT? Because I can imagine that the value to the academic community and to these organizations in aggregate is very high, but for any one individual organization to like invest the resources and time in running something like that, it barely ever makes sense because they're so resource scarce. So how do we kind of balance that trade-off and help support more?
Yeah, so I mean, we started off with like a public health background, and like I was doing my master's thesis in public health, and it kind of came out of that hey, we want to evaluate. We very early on knew that we wanted to evaluate whether or not our system would actually improve a health outcome like infant immunization. And we were lucky that we got a research grant from an organization called 3IE that was based off. We actually did initially a first smaller trial with an NGO, had some mixed results or non-significant results. And then we used that as a basis to apply for funding for this larger trial. And they were like, okay, at least you've tried it. You have some experience on the ground. This looks interesting. And we were able to win that research grant. And from that research grant, we were actually able to establish a head office, like build out our platform a little bit and make our money go further than just what it was intended for, which was the research. But I think to your larger question, a lot of nonprofits may not have the technical skill sets when it comes to data science, impact evaluation, health econometrics, epidemiology, let alone big data skills that are becoming increasingly important for even the larger NGOs that are working in the space. So I think there is a huge skill gap and talent gap, because I think partly due to lack of awareness, but also how the market landscape looks like, right? So you'll have people that go into academia, you'll have people that go into industry, but there is this like kind of missing area of social impact where hopefully people from who all have already gone into academia or industry can feel that they are still welcome into in some capacity. I think that's, or people can go directly into that full-time, either way, where that's the thing that we kind of want to get the message out about.
Amazing. There's so much for us to process and learn from everything they presented today. So I know that you have to run. So we'll end it there. But thank you so much again, Ruchit, for taking the
I'll
time.
put my email in the chat in case anyone wants to reach out. But yeah, thank you so much. And thank you all for your time.
We really appreciate it, Ruchit. Have a wonderful day. And
You too.
we look forward to continuing following all that you do at Cushy Baby.
Thanks so much. Bye-bye.
Thank you.